Today I'll be presenting on pulse oximeters. They are inexpensive medical equipment that has become one of the most widely used tools for patient health monitoring. Pulse oximeters measure an individual's oxygen saturation. Despite their apparent simplicity and commonplace use, pulse oximeters have had a profound impact on how physicians monitor oxygenation in real time. This session will discuss their history, several clinical applications, the scientific concepts underlying their operation, and the ethical and societal challenges that have emerged as their use has expanded globally. Finally, we will examine recent advancements and possible future directions that aim to address these issues. Why oxygen matters. Cellular metabolism depends on oxygen, and even little decreases in arterial oxygen saturation can quickly become fatal. Arterial blood gas analysis has long been the gold standard for determining oxygenation. Nevertheless, this approach is intrusive and is unable to offer constant real-time monitoring. In acute care, when proper identification of hypoxemia is essential to avoiding organ damage, this poses a serious problem. By offering a straightforward, non-invasive method of continually measuring oxygen saturation, the pulse oximeter filled this gap. Historical development. Researchers first used light to examine blood flow and oxygenation in the 1930s, which is when pulse oximetry got its start. However, Japanese bioengineer Takuo Oyagi created the contemporary pulse oximeter in the 1970s by examining the shifting ratio of light absorption at two distinct wavelengths, red and infrared. During the pulsatile flow of arterial blood, Oyagi found that arterial oxygen saturation could be computed. This insight was groundbreaking at the time, since it allowed for the indirect measurement of oxygen saturation without drawing blood. Principle of operation. A simple application of the Beer-Lambert equation, which explains how light is absorbed as it travels through a substance. It forms the basis of the pulse oximeter through a vascular bed, typically the earlobe or fingertip. The gadget releases two different wavelengths of light, infrared light at 940 nanometers and red light at about 660 nanometers. These wavelengths are absorbed in different ways by oxyhemoglobin and dioxyhemoglobin. While dioxyhemoglobin absorbs more red light, oxyhemoglobin preferentially absorbs infrared light. The amount of light that enters the tissue at each wavelength is measured by absorption to differentiate arterial blood from venous and tissue components because the volume of arterial blood varies with each heartbeat. The device determines the percentage of oxygenated hemoglobin, represented by the value SpO2, by dividing the amount of absorbed red light by the amount of infrared light. This approach is accurate within 2 percentage points of arterial blood gas measurements under optimal circumstances. Clinical applications. In several branches of medicine, pulse oximetry has become an essential tool. Continuous oxygen monitoring during surgery is now a commonplace in anesthesia and has greatly decreased complications associated with anesthesia. Clinicians can identify hypoxemia early in critical care and emergency rooms, frequently before symptoms like cyanosis manifest. Pulse oximetry improves early diagnosis and outcomes for neonatal care by screening for serious congenital heart defects soon after birth. Pulse oximeters are used by patients with long-term respiratory disorders, such as sleep apnea or COPD, to check their oxygen levels at home. Pulse oximeters were essential to home monitoring programs during the COVID-19 pandemic because they enabled medical professionals to remotely monitor patients and take action when oxygen levels unexpectedly decreased. The pulse oximeter's wide range of uses demonstrates why it is regarded as a standard of care in contemporary healthcare systems. The ethical and social issues. Serious ethical concerns regarding the developmental and control of medical equipment have been brought up by the problem of racial bias in pulse oximetry measurements. According to a groundbreaking study in 2020, occult hypoxemia or low arterial oxygen saturation that is not picked up by pulse oximetry. It was 3 times more common with black patients than with white patients. Inadequate calibrations during device development could cause this data, which frequently uses data from people with lighter skin tones as a bias of this. Disparities in availability to trustworthy pulse oximeters continue to exist worldwide. Hospitals frequently lack the necessary equipment or are forced to use inexpensive models with dubious accuracy in low-resource environments. Unfair health consequences are a result of these inequities, especially during international health emergencies like the COVID-19 pandemic. These moral dilemmas draw attention to the necessity of more equitable distribution of medical technology, inclusive calibration datasets, and improved regulatory oversight. In conclusion, the pulse oximeter is a fantastic example of how a little, very simple device can have a big impact on global health. Its non-invasive, real-time monitoring capabilities have transformed clinical therapy from the operation room to the patient's home. However, its widespread use has also highlighted significant disadvantages and ethical conundrums that require attention. Careful solutions are necessary to address issues such as bias in readings, unequal access, and excessive dependence on faulty equipment. The sustained effectiveness and equality of pulse oximetry in the future will be contingent upon continuous innovation, inclusive design, and regulatory reform.